Asefa from the National Institute for Global Health at the University of Melbourne. I will be presenting on imagining maternity care as a complex adaptive system, understanding health system constraints to the promotion of respectful maternity care in Ethiopia. As a background, in Ethiopia, there has been a remarkable improvement in maternal health. For example, maternal mortality reduced from more than 1,000 in 2000 to almost 400 in 2019. Similarly, the utilization of maternal health care services increased significantly. However, there is a mismatch between antenatal care and facility-based childbirth. This shows there are women who had at least one antenatal care visit during their pregnancy, but who still deliver at home. Among the main reasons that result in outside health facility delivery or childbirth in Ethiopia are perceived poor quality of care, bad experience of facility-based childbirth, disapproval from elders, nighttime labor, hostile or unfriendly staff, disallowance of birth companions, lack of privacy, and poor structural readiness of health facilities. This constellation of factors are nowadays labeled as mistreatment or disrespect and abuse. In response to the increasing levels of mistreatment during facility-based childbirth globally and in low and middle-income countries, the World Health Organization included respectful maternity care as one of recommended practices for positive childbirth experience. Accordingly, the WHO defines respectful maternity care as the care organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth. Accordingly, respectful maternity care spans the health, legal, human rights, political, and social sectors. And it is also an issue of people-centered healthcare. This study aimed at identifying health system constraints to the promotion of respectful maternity care in Ethiopian health facilities. And we used the displayed conceptual framework to unpack or identify barriers to respectful maternity care implementation at individual, facility, program, and socio-political levels or factors. This study makes part of an interventional mixed methods design that was conducted as part of my PhD study. So the quantitative wings included survey of women and survey of service providers, and the qualitative ones included focus group discussions with service providers and in-depth interviews with coordinators and managers. This particular study reports on the qualitative wings. The other components will be reported in two poster presentations that are also presented in the GLOW. The intervention included 3-day respectful maternity care training to staff who work in labor and delivery wards of the hospitals, placement of WHO infographic wall posters, and post-training on-site continuous quality improvement support. The intervention was implemented in 3 hospitals, 2 general hospitals, and 1 primary hospital in southern Ethiopia. From the 7 FGDs, 4 of the FGDs were conducted pre-intervention and 3 were conducted post-intervention to explore how service providers experienced the respectful maternity care training and the challenges that they encountered in implementing the respectful maternity care recommendations. And there were also additional 12 in-depth interviews with hospital administrators, service coordinators, and a program manager, which were conducted all pre-intervention. For data analysis, we used a hybrid thematic analysis approach that used both inductive and deductive approach. The deductive approach depended on the complex adaptive systems theory, which I'm going to describe. So a complex adaptive system is a type of system that comprises diverse agents, and the behavior of each agent is responsive to the interactions with other agents within the system. So there are different subsystems with cross boundaries and that exhibit dynamic interaction or relationships, and their behavior is determined by that dynamicity or complexity in interactions. So using the hybrid thematic analysis, we identified 7 major themes with regards to health system barriers to the implementation of respectful maternity care. And we classified those 7 thematic areas into system hardware and system software constraints. The hardware included issues regarding bed availability, infrastructure and supplies, financing, and health workforce, whereas the system software included staff motivation, service providers' mindset, and awareness of respectful maternity care. Here are pictures that show the challenges in the study hospitals. As you can see, there are 4 birthing coaches in one room without a physical compartment, and you can see the existing privacy screens are very old and with rusts. And one of the hospital coordinators said the main challenge in their hospital is shortage of beds, especially during night time. Sometimes it is the gatekeepers who tell women coming by ambulance to turn around and look for other hospitals in the city. There are also issues or challenges in terms of shortage of service providers because of financial constraints, and also there are issues related to delay of reimbursement of fees for maternal health services from the Ministry of Health. In Ethiopia, maternal health services waived, but the hospitals get reimbursement from the Ministry of Health. So one of the managers said there is a huge delay in getting costs incurred for the delivery of childbirth services, and that is significantly affecting the quality of service that they provide to women and their families. Here, a causal loop diagram shows how complex the respectful maternity care service provision is in the study hospitals. There are different problems in those 7 categories or health system constraint categories. For example, issues related to supply, issues related to financial shortage, issues related to staff retention. So the relationship or the interaction between those different compartments is very complex, as we have seen, and some exhibit positive feedback loop as can be seen from workload and fatigue and turnover of midwives. The more midwives leave the hospitals, the more the remaining will be exposed to higher workload, and that repeats itself viciously. So there were complex interactions between various system elements in the absence and with the presence of the intervention, and a system constraint can affect both clinical and non-clinical maternity care components in various ways, and an intervention component may have a positive or negative consequence on other components. For example, in this study, after the training, service providers allowed women to have their birth companions, but that affected the privacy of other women, especially during vaginal examination, and that practice was terminated afterwards. The study is unable to explore how systems adapted further after the post-intervention FGDs because of resource constraints and short follow-up after the intervention in this study. So the way forward is strengthening health system using bottom-up and top-down approach to intervene at micro, meso, and macro level. Here I have synthesized evidences from various studies conducted in Sub-Saharan Africa and in Ethiopia to show how respectful maternity care can be intervened at women and community level, service providers and managers level, health facility level, and national level. And the bottom row shows various interventions that were identified to be effective in yielding results. In summary, promoting women's rights through respectful maternity care, advocating providers' rights, and health system strengthening results in the elimination of mistreatment and improved quality. That would in turn provide improved institutional delivery, which results in reduction of maternal and neonatal mortality. Not only this, respectful maternity care also improve positive childbirth experience among women. I would like to thank all partakers in this study for financially supporting my PhD study and all study participants who took part in our study. Thank you very much.